Thank you, Gabriel, and thank you everyone for joining us a little bit later than usual today. I plan to share with you an update on the epidemiology of COVID-19 in King County, a little bit of information about the ACIP decision this afternoon on the Johnson & Johnson vaccine, and an update on our vaccination status in the county. As of yesterday, there were 95,062 confirmed cases, 5,621 hospitalizations, and 1,500 confirmed deaths due to COVID-19 in King County. This week's forecast is for increasing storm clouds on the horizon. Over the past week, 344 new cases were reported daily. That's up 11% from the prior week, and more than double what we were seeing in early March. The 14-day incidence rate, and this has a 7-day lag as per our Department of Health, has been rising since early March and is approximately 214 per 100,000. And that's similar to last week, but about double what it was at the end of the fall-winter surge in early March. Incidence rates have been trending up for all age groups except for ages 65 and older and under 5 years of age, with the highest rates again in 18 to 24-year-olds, followed by 25 to 49-year-olds and 5 to 17-year-olds. These age group trends are similar to what we've observed throughout most of the pandemic after the initial wave in long-term care facilities, with the important exception of the recent sustained decline in cases among older adults. Overall, COVID-19 incidence remains the highest in cities in South and Southeast King County, including Auburn, Kent, Federal Way, Burien, Renton, Tukwila, and SeaTac, in Southeast County, including Covington, Enumclaw, and in West Seattle, South Seattle, Delridge, and Highline. Over the past 14 days, these areas continue to experience double to triple the number of cases and hospitalizations compared to Central and North Seattle, Shoreline, the East Side, and Vashon Island. Hospitalizations are continuing to rise, and they have been since early March. Over the last 7 days, 120 King County residents were hospitalized with COVID-19, and that's up 25% from the prior week, with one person now hospitalized every 1 hour and 24 minutes in King County. Our hospitalization rate is 4.9 per 100,000 per week and climbing. That's approximately 3 times what it was in early March, and now it's about 1/2 the peak that it was at during the fall and winter surge. The greatest number of recent hospitalizations are in 40 to 69-year-olds, followed by 20 to 39-year-olds. And again, over the last week, more 20 to 29-year-olds were hospitalized than people who are over 70 years of age. The increasing number of hospitalizations among young adults reinforces that although the rate of hospitalization is relatively low in this group, when COVID-19 is widespread, severe cases will occur even in younger adults. And there's new research that was published this week in the journal Nature that found an increased risk for long-term medical problems in people with COVID-19, even though they were not hospitalized at the time for their illness. And this includes both lung issues from the respiratory effects of the virus and symptoms that affect almost every organ system of the body, from neurological to cardiovascular to gastrointestinal. There are also greater risk for mental health problems, including anxiety and sleep disorders. So this really emphasizes that COVID-19 can cause severe disease in people of all ages, even in people who don't need hospitalization for their illness. And there's still a lot we don't know about the disease and its long-term health impacts. This emphasizes the importance of preventing as many cases as possible. Prevention is so much better than regret. Our weekly deaths remain comparatively low compared to the fall and winter surge. On average, over the past 3 weeks, 1 or 2 residents have died of COVID-19 every day in King County, compared with 9 deaths per day during the winter peak. With protection of older adults through vaccination, the proportion of deaths in younger age groups is increasing. Over the past 28 days, 8% of deaths have been in the 25 to 49-year-old age group, compared with 2.5% overall during the outbreak. And 27% of deaths over the past 28 days have been in the 50 to 64-year-old age group, compared with 13% during the outbreak as a whole. The proportion of deaths among adults 65 and older has fallen from 85% overall to 65% in the last 28 days. And although less frequent than in seniors, COVID-19 can cause serious illness with hospitalization and death in younger adults. Now, I'll speak a little bit about the metrics for the current phases of reopening. Our current metrics put us at very high risk for rolling back to phase 2 of Washington State's roadmap to recovery plan. We are at 214 cases per 100,000 over 14 days. And our metric for phase 3 calls for that number to be below 200. And we are at 4.9 per 100,000 over 7 days in hospitalizations. And our metric calls for that number to be below 5. And there is a 7 and 10-day lag respectively in the calculation of these numbers to assure completeness of data. The state will next evaluate King County's metrics and phase placement on the 3rd of May. Now, we are continuing to sequence more of our COVID-19 isolates at area laboratories, and the current rate is about 11% of all COVID isolates being sequenced, which is very good. Most COVID-19 in Washington State, as well as the US, are now due to variants, which are more transmissible. And in the case of the B.1.1.7, which is the most prevalent variant identified locally, also is likely to cause more severe disease. And these more infectious variants represent a significant and increasing threat to our ability to bring this outbreak under control. We've now had more than 1,400 variant cases reported in King County, and we know that this is not an accurate assessment. This is just a sampling of a small percentage of all the viruses that infect people each week. So we are confident that, as in the rest of the state and in the country, the majority of viruses that circulate in the community right now are variants of concern. I'll talk a little bit about some new guidance that we've put out because with increasing transmission and increasing risk, I need to remind everyone that COVID-19 spreads primarily through the air, and it's mostly at close contact, but at times it can spread over longer distances indoors. And this has important implications for prevention. The risk is greatest indoors with crowded settings, when ventilation is not good, and when people are not wearing masks. Loud speaking, singing, aerobic exercise can all increase the amount of virus in the air and the risk of spread. So everyone needs to pay more attention to ventilation and airflow. For employers and building managers, we have excellent new guidance online to help you understand and improve indoor airflow to reduce the risk of COVID-19 transmission. And you should be able to see the URL during this presentation where that information can be obtained and downloaded. Please remember, outdoors is better than indoors. If you have to be indoors with others, open windows and doors and keep it brief. And it is true that cleaning and sanitizing surfaces is a good practice in general, and it's important. The risk of COVID being transmitted via surfaces is low, and we all need to understand how this disease spreads through the air and do whatever we can to minimize that risk. So in summary, King County entered phase 3 with the rest of Washington State on March 22nd, at a time when cases and hospitalizations were already on the rise. Since that time, our 7-day average case numbers have risen by 70%, and hospitalization rates have increased by 75%. Now, we all knew it would take a significantly stronger effort to counter the effect of more contagious variants at the same time we entered phase 3 and loosened restrictions. And as of today, this surge has continued to grow despite the precautions we're currently taking as a community. Thankfully, vaccination has largely protected many of our older, most vulnerable adults. However, we don't yet have enough younger adults vaccinated to counteract the increased ease with which the variants spread. And over the past 6 weeks, we've seen increasing numbers of people infected and hospitalized. Now, we do continue to make progress, with 57% of adults having received 1 or more doses in King County and 36% fully vaccinated. But almost 2/3 of our adults are not yet fully vaccinated. So the threat from this variant-driven outbreak remains real, and we need not only to continue with, but to strengthen our actions to prevent the spread of COVID-19 over the coming weeks. To protect yourself and those around you, limit activities with unvaccinated people from outside your home. Avoid crowded indoor spaces. Pay attention to improving ventilation in workplaces, businesses, and homes, including by opening doors and windows, and wear a well-made, snug-fitting face mask. Remember, COVID-19 spreads primarily through the air and often from people who do not appear to be ill or before they develop symptoms. Now, a couple of words about the breaking news from the Advisory Committee on Immunization Practices regarding the J&J vaccine. It's clear, based on information presented today, that on both the population health and individual health levels, the benefit-risk ratio of this vaccine favors its continued use. The ACIP therefore recommended for all persons 18 and older continuation of availability and use of this vaccine with a warning that will accompany the product information from the FDA on the product sheet about rare potential adverse events and with information for patients on what to look for to allow early identification, prompt treatment, and reduction in risk of potential bad outcomes from these rare events. So for example, on the population health level, depending on the uptake of vaccine, we would expect to see over the course of the next 6 months with full use of this vaccine, 26 to 45 rare cases of thrombotic thrombocytopenic syndrome. At the same time, realizing the following benefits: 600 to 1,400 fewer deaths and 800 to 3,500 fewer ICU admissions. Even in the younger women, 18 to 49 years of age, for every 1 million doses of vaccine, there would be expected 13 cases of the rare thrombotic thrombocytopenic syndrome, while at the same time, we would be avoiding 12 deaths, 127 ICU admissions, and 657 hospitalizations. So the benefits clearly outweigh the risks, but people do need to understand the risks and be able to make a choice when they have a choice about what vaccine they prefer and what vaccine is best for their particular situation. Now, moving on with vaccine, this week we hit a milestone in King County with over 1 million residents 16 and older having received at least one dose, and that represents 57% of our residents with one dose or more, which is outstanding. 36% are fully vaccinated. And among our older adults, 90% of residents 65 and older have received at least one dose, and that's compared with 80% across the US, and 78% have completed the series, compared with 66% across the US. By race and ethnicity, we have now 78% or higher one-dose vaccination coverage across all racial and ethnic groups for adults 65 and older. And when we look at the 16 and up age group, we see some disparities now. Among white, Asian, and Native Hawaiian, Pacific Islander, and Native American residents, we see single-dose vaccination rates in this age range of 54 to 63%, while among our Black and African American and Hispanic residents, single-dose vaccination rates are lagging at 40%. So we still have a vaccine equity gap in the younger adults that we need to work hard to close, and we are continuing to do that. We also have a lot going on this weekend in that vein with community-focused events, including vaccination events at Garfield Community Center in Seattle Central District to serve the Black and African American community, a community-led vaccination event at the Gurudwara in Renton, focused on underserved and essential worker communities within the larger South Asian community in South King County, and a vaccination event in the town of Pacific to reach indigenous communities from Mexico and South America. We also have a lot going on with our mobile teams to reach vulnerable populations with 19 mobile teams in the field, serving homebound people. We've served 370 through homebound vaccination visits so far. And we've got the ability now to serve homebound, and those appointments are available by calling our call center, which will be posted for you so that people who are eligible for in-home vaccination can schedule appointments. We've also had our mobile teams out visiting 53 homeless service sites. Last week, we were able to replace all the planned J&J doses with Moderna and didn't have to cancel any clinics, thankfully. With respect to our supply and demand, this week we received approximately 115,000 primary doses, first doses throughout King County, which is very good. We expect to receive the same or slightly more next week. And we know that as about a week ago, we had about 800,000 people eligible for vaccine in King County now with open eligibility. And so we really look forward to being able to serve people as quickly as possible as we receive more and more doses. Unfortunately, on that front, although Department of Health projects the state supply will remain relatively flat, we are receiving additional doses through some of the federal programs like the Federal Pharmacy Partnership, which brings additional doses into King County. So I encourage everyone to check with the regional pharmacies for appointments. And also HRSA will be increasing doses to our community health center colleagues. So despite all this, it still is difficult, we know, to secure vaccination appointments. We're working as hard as we can to get vaccinations to you as quickly as we get doses available. Piece of good news on that front is that our Kent and Auburn sites received extra doses this week. And as a result, we have open appointments available for those living in South King County, including an all-day clinic at the Kent location on Sunday. And you can check our COVID website to schedule an appointment. So with that, I'd like to pause and take your questions. Thank you again for joining us today.
Thanks so much, Dr. Duchin. Members of the media, if you have a question, please use the raise your hand function in Zoom, and we'll do our best to get to everybody. And time permitting, we'll also include some questions from members of the public watching on Facebook. Our first question comes from Jessamine McIntyre. Jessamine, please, oops, I'm not sure if I can unmute you here, so I might need one of my comrades to make me a co-host so I can unmute you.
Think as long as you can hear me.
Yeah, there you go.
Thank you very much. I appreciate it. Dr. Duchin, I was listening in on the ACIP call this morning. We do know that there was a vote to recommend the continued use of Johnson & Johnson, but do you foresee more vaccine options right now for those who might want a choice in their given vaccine? I know you briefly touched on that. And how much hesitancy will you have to combat just because it's furthered following that pause in the use of J&J?
Mm-hmm. Thank you. Two important questions. Will we have choices? We do have choices currently in the community. It may not be convenient for everyone to find the vaccine of their choice. And again, right now with our outbreak increasing, you have to weigh your preferences and the risk and benefit of getting vaccinated now versus waiting. And there is significant risk to waiting to be vaccinated for some people, particularly those who are out in the community. Now, if you can stay home and away from others and you don't feel like you're not at risk of COVID and you want to take your time and pick and choose, that's, I think, a reasonable thing to do. But for people who are at high risk, who live in congregate settings, or who are otherwise exposed to a lot of others in the community, the best option still from the public health and the individual risk perspective is to get vaccinated as quickly as possible with whatever vaccine is available to you. For those who do wish to wait, we can and do let people know what vaccines we're offering at our sites. People can ask when they are scheduling a site what vaccine is available, and they can choose one that is more desirable to them. Many people, we were told, were quite upset, and I'm not sure that during the J&J pause, because that vaccine is quite attractive and has many advantages, particularly the fact that it's only one dose and has fewer of the immediate side effects that some of the two-dose vaccines have after the second dose. And it's highly effective against severe illness and hospitalization and death, just like the other mRNA vaccines. So we always have had, and we will continue to have, barring any additional unforeseen problems with vaccine production, we anticipate we'll have 3 formulations available in the county for people to access at their discretion. But I do want people to understand that with our outbreak increasing, there is significant risk in the community, and everyone needs to make a judgment based on their own particular circumstances, how urgent it is for them to get vaccinated and the risk of waiting. We do know, based on the analyses and the very careful work that has been done by our CDC colleagues, that the benefits both on the population and an individual level of receiving the Johnson & Johnson vaccine outweigh the risks of not getting it.
Thanks so much. Our next question comes from Nick Popham. Nick, please go ahead.
Thanks so much, Dr. Duchin. My question is, when you're looking at current case rates and hospitalizations in King County, what's concerning you most right now? And I guess, what are we failing to do effectively to counteract what's happening? Obviously, people are getting vaccinated, but what's happening in our community that's causing these cases to continue to rise? Is there something that we need to do better overall in the county? Thanks.
Thank you. Well, rising COVID-19 rates concern me. Rising hospitalizations concern me. I'm very relieved that the numbers of deaths are low, and that's a tribute to the fact that so many older adults have been vaccinated. It's just a fact, though, that a sad fact that these more transmissible variants that spread much more readily from person to person were reaching our community just as we were getting our vaccination program up and running. If we had had the opportunity to fully vaccinate our population, we wouldn't be seeing this. But the fact is, still many adults have not been fully vaccinated, and these variants of concern are spreading widely. So what concerns me is that there are still so many vulnerable people. 2/3 of our adults approximately are not yet fully vaccinated, and there's a lot of virus spreading. So there's a potential for many more people to become sick, and many more people to become hospitalized, and relatively few, deaths, relatively speaking. But any preventable death, in my opinion, is something we should strive to avoid. So what we need to do is to continue to vaccinate as quickly as humanly possible, and that's strictly a function of the number of doses that become available to us. And then we need to, unfortunately, exercise our restraint and do the things that can stop this virus in its tracks immediately. Vaccination is going to take some time, and it also takes time to build immunity after you've been vaccinated. It takes about approximately a month or more to be highly protected after either the J&J or the 2-dose series vaccines, and so it's not something that can stop spread right away, like limiting your interactions with others can, by avoiding lots of close contacts with other people, by avoiding crowded indoor air spaces, by gathering less, by making sure places are highly ventilated, and by wearing masks whenever around other unvaccinated people indoors and outside the home. That is what's really going to stop the spread. That is what can stop the spread most effectively. The so-called lockdown-like behaviors are the most highly effective in interrupting transmission. Now, of course, those come at great cost. And so we have to try and balance in the community what is feasible versus what is necessary. But I think at this point, clearly, what we've been doing is not adequate to stop transmission with respect to our behaviors. And if we want to minimize the number of people getting sick, the number of people getting hospitalized, the number of people that may be at risk for long COVID and chronic complications, and the number who die, we need to be more serious and more effective in our COVID-19 prevention measures as we get more people vaccinated. And on this topic, I neglected to answer the second part of Jessamine McIntyre's first question about vaccine hesitancy. Am I concerned about it? I'm concerned when people don't take advantage of an intervention that can keep them healthy and prevent them from getting sick, hospitalized, or die. And I know that people have many different reasons for being hesitant, and we are trying to provide as much information and reassurance about vaccine safety and any other concerns that people have to help them make good decisions. I really don't know whether the pause in J&J is going to meaningfully impact people's attitudes about vaccination in our area. I do think that it is incredibly clear that and undeniable that our national vaccine safety system is very sensitive, and that we place vaccine safety at the top of the priority list for our national COVID-19 vaccination program. And that was exemplified by the pause that was taken. Many people said we shouldn't have paused. We just, because the vaccine is so valuable, we should have continued to use it. But the ACIP felt that they wanted to make sure they understood what was happening and that they understood very carefully the benefit and risk before making a recommendation to unpause. And that was done today because that risk-benefit ratio clearly favors ongoing availability of this vaccine. So I think many people will be reassured that an effective and attractive vaccine to many people is now going to be widely available again. For those who have concerns, we're here to help answer questions, and I hope people will continue to make good decisions about not only protecting themselves, their families, their loved ones, their social contacts, their coworkers, but our community at large.
Our next question comes from Evan Bush. Evan, please go ahead.
Thanks for taking the question. Jeff, I'm wondering what your message would be to women who are 18 to 50 years of age and considering the J&J vaccine, particularly with some of the ACIP committee members voting against today because of concern that that those greatest at risk for TTS may not be sufficiently informed.
Yeah, it's a very important question, and this issue of informing people about this rare risk is very important. It was clear that, both at the population level and on the individual health level, the benefits of this vaccine are very strong compared to the risks, that outweigh the risks in favor of the continued use. However, people should have the opportunity to decide what risks they take with respect to their personal health. People take medications and undergo medical procedures all the time that carry risk, but they make a choice about it. And so with vaccination, it should be no different. People should understand that there is a risk of a rare, potentially serious side effect from the J&J vaccine, but at the same time, their risk of getting a serious outcome from COVID-19, including hospitalization, death, or ICU admission, is higher. That outweighs that risk, but people, have different tolerance for risk. So what we will be doing, and I'm sure across the country, what people will be doing is clearly publicizing the information that we have about the benefit to risk ratio, that people should be reassured that this pause allowed us to study and understand the risk very clearly, that it remains very low, but it is present, it is not zero, and that women may choose to opt for a different vaccine if they are extremely risk averse, or they feel like the risk of contacting COVID is very low, so they don't want to have even a minuscule risk of an adverse vaccine side effect like this. They may opt for a different vaccine. But for someone who is exposed to the public, who has more of a risk for COVID, the higher your risk of being exposed, and right now in the US in general, and here in particular, the risk is increasing. The benefit of the vaccine does outweigh the risk, statistically speaking. But people do need to be informed that there is a risk, just like there's a risk with every medication someone might take and everything we do in life, but that this vaccine remains very safe overall. So it's part of that. In the new information that will be given to patients, the FDA is including explicit information about this risk and how often it occurs. And then also more practical information will be given to patients about what to look for, the symptoms, and that the symptoms that you'll hear about, and this can be a little bit confusing, include headache. Now, headache is a very common symptom after vaccination for some people. It occurs typically the day after vaccination and lasts for a day or two. Sometimes it's severe, but typically it's not. The headache that has been associated with this syndrome is different. It typically occurs later on around day 6. So after the headache that might be commonly experienced with a vaccination, and it tends to persist and be more severe. So symptoms like that, in addition to things like, chest pain, abdominal pain, pain in the legs, things that might indicate a blood clot occurring, are different than the benign sort of headache and malaise, flu-like illness that people may feel after vaccination. So it will be important for people to be educated about, what type of symptoms should lead them to seek medical care, because if you do have this very, very rare syndrome, getting it identified, diagnosed, and treated quickly is definitely helpful. So that's why we want to make sure that even though this is uncommon, the rare people that may experience it can get the best and most prompt treatment.
Thanks so much. Our next question comes from a member of the community watching on Facebook, and the question is, why don't you move the county to phase 2 now when waiting a week could only increase the case rate?
Yeah, it's true. Waiting a week could increase the case rate. It's a very reasonable question. Waiting a week could also see us turn the corner and have the case rate go down. And we're basically straddling the line. It's not a magic sort of threshold where crisis on one side and halcyon days on the other. This is a gradation, a increasing level of risk in the community, of impact, of adverse health impacts, that is something that is unpredictable. And right now we're very much straddling that line where we would go back to phase 2 if both our hospitalization and our case incidence passed the line. Officially, our case rate is above the line, our hospitalization rate is below the line. And what we're seeing today is based on the types of behaviors people did a week, 10 days ago with respect to transmission. And what we do today will determine, what happens in a week or two. And that's why it's so critical for everyone to take these COVID prevention measures like decreasing activities, avoiding crowds and crowded spaces and close contact with others right now to the greatest extent possible. But the reason we don't go back to phase 2 right now is because we're not clearly above the limits, and because it's not clear, the stability of our trajectory above that level. We should be a little more reliable before we made that step, because it does have significant implications for many of our community members, businesses, workers, the economy, and we want to make sure that whatever action we take is taken on reliable trends in the data.
Thanks so much. Our next question comes from Elise O'Neill. Elise, please go ahead.
Thanks for taking our questions. Why do you think the COVID cases remain higher in South and Southeast King County? Is that just about essential workers, or what's going on there?
Mm-hmm. Yeah, it's a question that I ask myself every single day, and my team will tell you I ask them every single day. And I'm sure people across the country ask themselves in their communities every single day, why are we seeing disproportionate impact, higher case rates, hospitalization rates, and death rates in certain communities, particularly communities that are of color, with more Black and brown people, a lower socioeconomic status. And the reasons that I think make sense to us, although it's very difficult to prove these things, include things like more essential workers who have to go into more crowded settings, don't have the ability to telework, telecommute, isolate themselves at home, more multi-generational households with more people living in a home, more opportunities for spread, and potentially less trust or access to, or desire to access testing, and possibly less ability to comply with isolation and quarantine because of need for income, and less ability to isolate and quarantine safely in multi-generational homes or in homes that don't include private rooms for everyone and places for people to stay separate from one another. So there are a variety of potential explanations. And then there are the intangibles just around behavior, which we don't understand very well at all. You know, it's certainly not only Black and brown communities that have COVID-19 transmission, but they have been hardest hit. People's behaviors vary across the county, across race, ethnicity, culture, and geographies about the types of things they do, how they do it, who they do them with, the types of gatherings, the size of gatherings. These are things that are really hard for us to understand, but they all really impact the way a virus can spread through social networks. And so there may be something about social networks. There were several studies that suggested that in communities of color, for example, food stores and restaurants were smaller and less likely to be well ventilated. Even things like that, you know, potentially can lead to increasing rates of transmission in the community. So I think it's multifactorial. There are things that are inherent to the fact that some people have fewer resources and less ability to protect themselves, so to speak, by isolating themselves from others through telework, don't have a choice about staying home from work when you're ill and so on. And then there are things that are more related to people's personal behaviors, social networks, and so on that we understand less well.
Thanks so much. The next question is from Joey Thompson. Joey, please go ahead.
Hi, Dr. Duchin. Can you talk about how treatable the blood clots are when found, in the right time frame? And then do you think tying a county's, phase in reopening with vaccination rates might add an incentive for folks to get shots quickly?
Okay, so first with how treatable. These are really rare and newly identified conditions. So I think, we'll be learning a lot about the best ways to treat it. But currently, what's clear is that it's not treated the same way as conventional blood clots, and that's with heparin. So it's possible that heparin can actually make this particular rare syndrome worse. And it's advised not to use heparin, that physicians who are suspecting this syndrome in someone who is recently vaccinated use a non-heparin blood thinner, and also look at some other potential treatments such as intravenous immune globulin, which tends to help the platelet counts come up. So there are specific guidelines that have been issued by the American Society for Hematology. These are available on the web, the CDC website and the American Society for Hematology website, that will help patients do better than if they were not recognized and thought to have had conventional blood clots and treated inadvertently without the guidance from this organization, from the CDC. So it is treatable, and I think over time we'll see how the outcomes change with the guidance that is now available. And of course, the other big piece is, in general, recognizing the problem earlier is likely to improve outcomes as well. So that's another important reason for both the community and healthcare providers to understand the signs and symptoms and how to evaluate for this syndrome by the healthcare provider and how to treat it appropriately early. Both the combination of early treatment and the specific treatment modalities that are recommended once this is suspected should improve outcomes, but it's too soon to say with any certainty, how much and what that will look like, because again, there are just so few cases, total that have been recognized that you really can't generalize, and we certainly don't have enough cases that have been identified after the new recommendations were put in for the specific therapies that may help most effectively, and also people coming to attention now theoretically more promptly than they had been when the syndrome was first recognized. What was your second question? Sorry.
I was in reference to tying vaccination rates with county phases.
Yeah. Yeah, I'd have to think that one through a little bit more closely. I mean, clearly, what you're saying makes a lot of sense. I mean, the more people that are vaccinated, the less likely we'd want to have or need restrictions. I think, though, that, the more people we have vaccinated, the fewer people we should see getting sick. Those two things are closely related, right? The point of vaccination is to lower the number of people who develop COVID-19, the number who get hospitalized, the number who die. So that's the bottom line. I mean, that's the thing that we're really trying to prevent, the clinical illnesses and the serious clinical illnesses, and making sure our hospitals are, able to operate safely. Vaccination rates are going to get us there, but if in the strange situation where we had high vaccination rates but continued to see lots of COVID transmission, we certainly wouldn't want to relax restrictions, because again, the most effective way to prevent transmission is through our behaviors, changing our behaviors to keep us farther apart from one another and safer, particularly indoors. So those two things are pretty much related. I'm not sure that, adding vaccination rates, would allow us to downplay or to diminish the importance of using illness and hospitalization rates as, the primary measure of what's happening in our community with respect to COVID-19 risk.
Thanks so much, Dr. Duchin. Our last question is just a clarification from a member of the community who's watching on Facebook and asking about the trends in COVID-related deaths. And is it the case that older deaths have been replaced with the same number of deaths among younger people, or have deaths just declined among the older age groups? Can you just clarify that?
Yes, sure. The majority of deaths have always been among the older adults, and the majority of older adults are now protected. So the number of deaths that we're seeing has dropped dramatically. It's particularly dramatic in those older adults who have been vaccinated. Younger adults have been and remain at lower risk of death, but because fewer older adults are now dying, the larger proportion of those deaths that do occur are among younger adults.
Great, thanks so much. And with that, if you have any closing thoughts, Dr. Duchin?
Yeah, thank you. Many of you will recognize that each week the stakes are higher as our outbreak continues to gain momentum, requiring progressively more effort to bring it under control. And vaccines are the very best tools we have to prevent COVID-19 outbreaks from starting in the first place. And by getting more people vaccinated, our entire community will be better protected. Every person vaccinated is one more case, hospitalization, or death prevented. And it also prevents transmission of COVID-19 and cases, hospitalization, and deaths in others. But right now, our outbreak is worsening, and the most effective way to turn it around quickly is to change our behavior and give more people the opportunity to remain healthy, stay out of the hospital, and avoid potential long-term health consequences of COVID-19. With a more effective community-wide effort to limit non-essential activities, avoid crowded indoor spaces and close contact with unvaccinated people, wear good quality and well-fitting face masks, and pay attention to improving ventilation in workplaces, businesses, and other indoor spaces, we can decrease the damage from this fourth wave and allow more of us to stay healthy and take advantage of our highly effective vaccines as they become increasingly available over the coming weeks. I want to thank you again for joining us today, and I look forward to talking with you next week.